Hey, can you look at my rash? A presentation by Cece, Diana, Sanela, Angela, and Cathy. Okay, so let's talk about our patient. Mrs. J is a 46-year-old school secretary who complains of pain that was burning and stabbing to the right flank area starting 1 week ago. She said that she first noticed the rash there a few days ago with small bumps and some blisters and some red patches. She's not had any other symptoms or fevers and is otherwise in good health. We've gotten some information from Mrs. J, but what else should we ask her? Do you have any allergies, medication or environmental? Have you ever had a rash like this before? Does anything make it worse? Has anything made it better? Did you have chickenpox as a child? On a scale of 0 to 10, how would you rate the pain of your rash? So we have Mrs. J in our office. Where do we start? We need to identify this lesion. So we found this awesome little flowchart, and it should help us come up with a diagnosis. We'll start at the top. Is the lesion solitary or are there multiple? And we'll go down from there. Is the lesion localized or is it generalized? And we go from there. These give us a general idea of what her rash could be. Well, what could this rash be? These are our top 5 differentials: poison ivy, HSV1, Coxsackie virus, bullous impetigo, varicella, or shingles. Now let's talk about poison ivy. This is a rash that happens when someone comes in contact with poison ivy, poison oak, or poison sumac. Poison ivy dermatitis typically presents as an acute, intensely pruritic eruption characterized by erythemas, papules or plaques, vesicles, and bullae. They're often arranged in characteristic, linear, or streak-like configurations where a portion of a plant has made contact with the skin. The diagnosis is made on history and exposure. Symptoms developed within 4 to 96 hours after exposure, and they peak between 1 and 14 days. Lesions may present in different locations and at different times. This is based on the amount of urushiol on the skin. This can often be confused that the eruption is spreading. The blister fluid is not antigenic. If untreated, it resolves in up to 3 weeks. Secondary bacterial infections can also present. Or maybe Mrs. J's rash could be HSV1. HSV1 can have cutaneous manifestations. They're called herpes gladatorum. They can occur on the face, neck, and arms, and they're due to close contact, likely exposure to saliva and superficial skin abrasions. Another option for Mrs. J is varicella or herpes zoster. Varicella presents as discrete vesicles with the disseminated distribution. The lesions develop in crops or succession. Patients present with malaise and fever. The vesicles later crust over and they can evolve into secondary impetigo. Varicella occurs during childhood, but it can develop in adolescents, adults, and immunosuppressed or immunocompromised individuals. If it does, it's more severe. Generally, these lesions occur on the trunk and spread to the face and the extremities. Herpes zoster, or shingles, is the manifestation of varicella later in life. It presents as a painful rash with vesicles that run along dermatomes, most commonly on the sides and back. Could Miss J have Coxsackie virus? It's also known as hand, foot, and mouth disease. It's a self-limiting condition that usually affects pediatric patients, but can also affect adults as well. The systemic virus causes painful mouth ulcers and painful white vesicles, erythema to fingers, palms, toes, and soles of feet. Typically, patients will present with a low-grade fever, a sore throat, and along with malaise for 1 to 2 days. Some patients will also have cervical or submandibular lymphadenopathy. Or could Mrs. J have bullous impetigo? This is a superficial pustular rash which erupts and then crusts over. Typically, bullous impetigo is described as honey-colored and is caused by staphylococci or streptococci. These bacteria get into the body through a break in the skin from a cut, scratch, insect bite, or rash. Impetigo is contagious. Most often, these bullous pustules are located on the face or trunk, but impetigo can erupt anywhere on the body. So we've reached our point for our assessment. We asked Mrs. J to show us her rash, and this is what we see. So what is her diagnosis? You guessed it. Mrs. J has herpes zoster or shingles. The varicella zoster virus, VZV, causes chickenpox and then can reactivate later in life, causing shingles. In the United States, herpes zoster occurs in more than 1.2 million individuals annually, and approximately 30% of persons in the United States will experience herpes zoster during their lifetime. It is important to educate patients about shingles and the risk of virus transmission. If a patient has shingles, direct contact with the fluid from the rash can spread VZV to people who have never had chickenpox or have never received the chickenpox vaccine. If someone gets infected from the blisters, then that person will develop chickenpox, not shingles. They then could develop shingles later in life. Patients who are immunocompromised also have a greater risk for getting shingles. The VZV can cause serious birth defects if a pregnant woman contracts the virus between 20 weeks gestation. Now that we've identified the rash, we need to talk about interventions that we're going to talk to Mrs. J about. These are the non-pharmacological ones. To prevent spreading VZV to others, you want to cover the rash. Avoid touching or scratching the rash. Wash your hands often. And avoid contact with the following people: pregnant women who have never had chickenpox or the chickenpox vaccine. If they are exposed, although rare, this can cause congenital varicella syndrome. You want to avoid contact with premature or low birth weight infants and people with weakened immune systems. Okay, what if Mrs. J needs some medications? All right, we're going to go to antiviral therapy. The goals of antiviral therapy are to lessen the severity and duration of pain associated with acute neuritis, promote more rapid healing of the skin lesions, prevent new lesion formation, decrease viral shedding to reduce the risk of transmission, and to hopefully prevent post-herpetic neuralgia, or PHN. To help prevent post-herpetic neuralgia, you want to start antiviral treatment less than 72 hours after onset of the first tingling or pain. Our options are valacyclovir, famciclovir, and acyclovir. Valacyclovir 1,000 milligrams 3 times a day for 7 days. Famciclovir 500 milligrams 3 times a day for 7 days. Acyclovir 800 milligrams 5 times a day for 7 days. In addition, for immunocompromised patients, you'll still want to start therapy even if they present beyond 72 hours of symptom onset. Herpes zoster or shingles can be very painful, so you'll want to think about analgesia for patients with moderate to severe acute neuritis. Although the antiviral therapy spoken about before reduces the pain associated with acute neuritis, some pain syndromes associated with herpes zoster can still be severe. So we'll use the same principles as managing any pain: mild pain, NSAIDs, and Tylenol. Moderate to severe pain, your choice of treatment is based upon the patient's comorbidities, concurrent medications, pain intensity, and preferences. You could try short-acting narcotics, some prednisone, but you'll want to taper it 10 to 14 days. You'll start at 60 milligrams per day. If not successful with the above regimens, you can use gabapentin or pregabalin. The gabapentin dose is 100 milligrams to 600 milligrams TID. Healthcare collaboration. Uncomplicated herpes zoster rarely requires additional consultation. Hospital admission and other specialty services may be required for those with severe symptoms, immunosuppression, atypical presentation like myelitis, involvement of 2 or more dermatomes, facial lateral superinfection, disseminated herpes zoster, ophthalmic involvement, ear infection, deafness, or Ramsay-Hunt syndrome, meningoencephalopathic involvement, and these require referral to infectious disease with hospital admission and an ophthalmologist if appropriate. These are our references. Thank you for watching, and we hope that you learned something today.